Nelson Schuster from the HSCRC, and we are going to go around. Our agenda today is to look at the MHAC program and go through our progress report. Again, the goal is that we will have a draft policy for the performance measurement work group to review at our next meeting on November 5th. We also are going to have a guest speaker today, Ann Greener from the National Quality Forum, and she'll be discussing the NQF's recommendations on sociodemographic risk adjustment. Before we get started, we're going to do introductions. We do actually have two new members of the performance measurement work group. Steve Davis has joined us. He has expertise in mental health that we thought would be valuable. He said he would be here. He may be coming in, and maybe we'll try to give him a few minutes. But we also have Andrea Benkoski. She's going to be our new DHMH representative, so we appreciate you coming. Should we go around and do an introduction?
Yeah, I think it will be helpful so for the ones on the phone know who is around the table. This is Shule Chilukolu from HSCRC.
Steve Ports, HSCRC.
Tracy Laval, the Maryland Hospital Association.
Linda Costa, University of Maryland School of Nursing.
Justin Dybel, Mercy Health Services.
Andrea Benkoski, DHMH.
Elsa Hiley, HSCRC.
Elsa used to work for DHMH.
And those of you on the phone?
This is Dan Cochran from Shady Grove Adventist Hospital.
Welcome.
And good morning. This is Fozzie Sabi, Mid-Atlantic from Montaigne Medical Group.
Okay. Very good. So I'd also like to thank the people who are here in the audience. We appreciate you attending, and we will make sure we leave time at the end for any comments or questions. So with that, we'll go ahead and get started, and I'll turn it over for Shule for the first part. First, we'll be going over the MHAC policy and discussing the current PPC trends.
All right, so I need help turning this on. Thank you. Good morning again. So what we thought we would do is go over some of the trends that we observed that we shared with you in the last meeting, and we did some further analysis, and we're going to talk about some auditing plans that we have. So you've seen this graph in the last meeting. We had a tremendous improvement in PPCs, which is good news, but at the same time, it's hard to understand. As you see, in a matter of 1 month, we had 17% reduction. And since then, we are continuing to decline in the PPC rates. So the good news is, the 30% target, hey, we aced it in 1 year almost. So we are trying to understand, obviously, most likely there are some documentation improvements, coding improvements explaining this trend. But we wanted to understand, the reasons, and maybe we can learn from it. So we looked at hospitals, see if any hospital was kind of the on the outlier side. So there's one hospital with the 100% decline, but that's McCready with 1 PPC only. So if you ignore that one, then it looks like, there is really not a one hospital standing as an outlier. Everybody, there seems to be almost like 3 groupings. One is around 40% declines, the other one's around 20% decline, and obviously we have a few hospitals that the PPC increased. So then what we did is, if you look at the Excel sheets that you have, so we are on the MHAC tables, table 2A1. So this is the same. So we graph the improvement performance year to date, so that's the purple towards the end. And you see the statistics by hospital. So McCready with the 100% decline, then Bayview with 44.7% decline. So this is comparing year to date, and I believe until August, right? year-to-date, so until August calendar year 13 to 14 rates. So we thought, okay, let's look at some of the exclusion categories. Are there changes in the way they are coming out? So we looked at the hospice cases, and you see there are big changes in the hospice cases. And we knew when we exclude the hospice cases, we discussed a lot, if you were around or you remember, the coding for hospice or palliative cases. I think this is hospice and palliative cases. So hospice cases were flagged in our data. Palliative cases were based on the ICD-9 codes. And it seems to me that and maybe this is the coding improvement, but the hospice and palliative cases also impact mortality. So we are going to be looking at how these are impacting the PPC cases. It may be just the mortality that is impacting the coding, not the PPCs, but nonetheless, definitely, I mean, would that be real? More than 100% increases in, it will be really nice. I actually, even if it is, there's some truth to it, I will be very happy that we are increasing access to palliative care. But it didn't seem to be realistic to me to have more than 100% increases in palliative care. Then the next column, we looked at the globally excluded cases. They didn't jump out too much, but still there are some big numbers there as well. And finally, if you take into account hospice palliative excluded cases, we wanted to look at the difference at risk. And this is a little bit impacted by the declines in admission rates too. So, we are still looking through the numbers. Then what we did is, the 17% we are seeing, even though you don't see an outlier hospital, there are some big improvements in larger hospitals. So when we look at it, for example, Johns Hopkins Hospital has improved by 40%, 29.7. And if you just weigh their improvement by their number of cases, they contribute 16% of the statewide decline. And then the next is Sinai, with they are contributing to the statewide by 8%. And Barbara just walked in. And then we have with, I'm going to revise the table and send you those numbers as well so you can see. But basically the largest hospitals that are contributing are Hopkins, Sinai, University of Maryland, and Bayview Hospital. So, trying to understand that trend, I think the story here is, all our hospitals improved, which is, good news, and our largest hospitals improved on the higher end of the spectrum, which contributed that big declines in the statewide trend. And then I think what we did is, the other question, is it a specific PPC? Is there any change in one particular PPC that is improving? So that's the second table, table 2A2. A similar logic here, we looked at the at-risk cases, observed cases, and the I think we had a. So in this case too, there is not a particular PPC that is jumping out to us as one that is improving. You see the numbers are kind of in a lot of them, the improvement is all over the place. And here again, we looked at the differences at risk and the PPC contribution to the total. So here you see, again, this is weighing the prevalence of the PPC. So if a PPC if we had more of those PPCs and they declined, even on the average, they are impacting the overall average. So looking at the last column there, the PPC contribution to total, you would see that if you look down, There are Ppc 55 obstetrical 1, 6% contribution, another 6% for postoperative hemorrhage. So again, nothing jumps out to us from these tables, and I would appreciate, when you look at these, and if you see things that we should be looking more, we'll appreciate your help. Yeah. Second page. Yep. And that was the coding. There was some coding issues with that one. I apologize. I did sort this by the improvement performance rate, but then we messed up our version, so it's hard to see. And lastly, the last table we have is the long table. And we said maybe, ICD-9, there are things changing in the way we are coding ICD-9s, how many codes that we have in each case mix changes. So the risk-adjusted rate controls for the case mix change, but we still wanted to see if there were changes in the number of ICD-9s, excuse me, coded for each case. So this one is looking at average number of ICD-9 coded per case, and this one is sorted. So that's sorted by the mean change. You see the Southern Maryland had the highest decline. So on average, they had 12 codes per case in 13, and now they have 10 codes per case. And then we did the distribution, so you could kind of see the 25th percentile median and the 75th percentile. So I don't think, the distribution is interesting to look at, but again, to me, it doesn't say much about the Ppc improvement that we see versus the number of codes that we see in the data set. It's not correlated. Nope. So our next steps are, we're going to look at that hospice cases and see how many of them had a PPC. And just as a background, when we discussed exclusion, the rationale was the hospice and palliative care patients, because of the way the care is structured, hospitals may not be able to prevent those PPCs. So, I think the rationale is still there, but we are concerned with the coding. Are there any comments or ideas that we should be looking?
Or observations from folks here who, are doing this stuff. Have you all experienced, seen anything happen either with coding or cases or anything that might explain this?
You mean explaining the improvement?
Yes.
Yeah.
Oh,
I mean, well, the 1 month improvement.
Oh, 1 month.
Yeah.
No.
So Barbara, here,
yeah,
let me put this back.
Yeah,
we've been getting commissioners are asking. We've been asking the question. Obviously, as Shule and Allison said, we're looking into it in various ways, auditing and otherwise. But I mean, are you all seeing anything out there that could be the reason for this 1 month decline, a huge 1 month decline?
My only comment would be, and first of all, I have to tell you, I was trying to be on the phone because I had a conflict, and I was on the music for half an hour, so I don't know if you have people on the phone or not. It was not possible to get through for a while.
Oh.
But anyway.
And note that it's like the beginning of the calendar year, the new performance year for the waiver and everything.
Well, the only thing I can say, and this is just from my quality exposure to other hospitals, everyone has been really working on quality issues. At 1 month, I have no clue, but I think there's been a kind of a culmination of just things starting to come together. I can't explain 1 month. I would say that it is worth looking at comfort care, hospice, et cetera, because the cross-check to that for hospitals is how the mortality rates look, and how hospitals are using that hospice and comfort care measure piece. But I can't give you an explanation for 1 month. I can just tell you that everybody is working extremely hard, as you see by the fact that the state is exceeding the expected 8% by a huge amount. And I'm speaking for my own hospitals that we have been working on quality for a year. So the 1 month I have no clue, but there's just a culmination of results coming through in many of the hospitals.
And of course, that's our question. Are we really exceeding it in terms of quality, or is it something else that, and
well,
that's what concerns us about that.
I can't speak to the month, but I can tell you at first, we all know there was a lot of cleanup on coding and just cleanup. POAs particularly, that goes way back. I would say now it really is the quality, because that's what's so slow. You're seeing that now catch up. People are working on aspiration pneumonia. People are working on renal failure. That's a hard one because it's sometimes just in the course of disease or in the course of surgery or something, but it could be temporary. But it's still, hospitals have been working very hard. What did you say, Tracy?
Yes, definitely. Agree 100%. Just to the point of what's the why the 1 month difference, a couple questions. I think I've probably asked these before, and I might know the answer, but I'm not remembering it. So, if I remember right, the graph, when we're looking at calendar 13 year to date, that's monthly cumulative. And so then when we start January, we're starting with a monthly rate in 14. So do we know what is the monthly, like the December 13 rate?
And you and I have looked at this, I think, and while it's not quite as dramatic as the year to date to the 1 month, so December to January, it wasn't so much less that we were concerned. I don't have the exact number in front of me, but we. Correct.
Yeah. So maybe we redo the graph, do rolling average all the way through, and see if it's a trend.
Well, it is a rolling average all the way through. It's just that when you start in January, you're starting.
Yeah, I think what you're saying is that's not a rolling average, and it's a month up, right? So what you're actually saying is that maybe redo the graph where it's a rolling that starts with, February.
Right.
Good point. I think good point.
Okay.
Yeah. So then if you don't look at that one, if you just look at the 24% change, that's what we've been. So all our tables has been the cumulative. So looking at the 9 month to 9 months, and the total decline there is 25%. So it's still, we were trying to say, okay, where is that 25% came from? And when you graphed it, it looked like there was a shift, but I think I agree with you. There could be some. I think it needs to be done on the rolling. Yeah. Yeah. Yep.
Right.
Yeah. Yep.
The other question I have, and I've probably asked this before too, but if you can help me remember, the risk adjustment. Are we using the same norm in 13 and 14, so it's the same risk?
Yeah.
Year. Okay, thanks.
Do you happen to have the July 12, and did you do the percent change from 12 to 13?
We have annual ones you're going to see towards the end of it. So, when we discuss what the next year target is, we'll get back to it. And can I just interrupt a minute? And Steve Davis just joined us. If we'll welcome him to the work group. And if you could introduce yourself, that will be great for people who don't know you.
Sure. Hi, I'm Steve Davis. I'm a physician, psychiatrist. I oftentimes represent the Maryland Psychiatric Society. I have a consulting company, Fuse Health Strategies, which we kind of focus on integrating behavioral health in primary care settings.
I ran the Department of Psychiatry at Baltimore Washington Medical Center for about 10 years. And I am at university as a clinical assistant professor. I was on listening to lovely hold music the whole way in. You don't have your thing on.
Right. That's what I was
Our apologies. Yeah, we other people made it through, but we may have had early on issues. So thank you again for joining us.
Yeah, thanks for having me.
But I think the question was, you have 1 year post.
Yep.
Mm-hmm.
Yes, we do. Not on a monthly basis, but okay. Let me close your eyes a second so you don't get dizzy. So we did the 10, 11, 12, 13. This was from last year, if you remember. So on an annual basis, so let's look at the, it's hard to see on the slide. Maybe you want to look at your printouts. The fiscal year 11 annual decline was 7.8% on a risk-adjusted basis. Then 12 was 10%. 13, we had a big improvement with 17%. And the 14 now is showing around 20%. So you see the in this one it's kind of annualized, so it doesn't look that dramatic, but the improvement is increasing basically.
What's the difference between those two complication rate lines?
One is risk adjusted and the other one is not.
Not. Okay.
The top one is not, bottom is adjusted. Yeah, they are cut off. All right, I'm gonna. So yeah.
Looking at this graph,
Mhm.
and you're looking at the rolling in 1 month, because it looks more dramatic, more like steady trend improvement.
Mhm.
Yeah, and I think we had originally had it month by month, and we changed it, but we'll look at it and figure out the best way to present it. So should I continue?
Mhm.
So
just one thing, when you look at fiscal year to fiscal year, we are actually capturing. If you think about this, so this is calendar year to calendar year. So then the number is 25% calendar year to calendar year. When you do fiscal year, we are picking up the highest portion of this graph in the measurement. So that's why in the annual fiscal year to fiscal year, it doesn't look as dramatic because majority of the declines are happening after January. Does that make sense? So, we'll.
You're saying that the 20%, 19.3
Mm-hmm.
could be increased further.
Yes. Calendar year shift, right. So this number over here, 25%, is looking at calendar year to calendar year with the nine-month data that we have.
So what we are going to go through next is sort of the HSCRC audit process for the present on admission indicators. We'll give a brief, really briefly go over POA. Then we'll talk about our coding audits and what we're planning to do for fiscal year 14, and then have a discussion around this. So again, POA definition, it's defined as being present at the time the order for inpatient admission occurs. Conditions that develop during an outpatient encounter, including the emergency department, observation, or outpatient surgery, are considered present on admission. Beginning in October of 2007, CMS required that all claims have POA indicators for hospitals that were in the IPPS system. Maryland hospitals were required to submit POA starting in July of 2007 and were required by CMS beginning with October 2013 discharges. And we will note that we've had some discussions about the POAs being submitted to Medicare on the claims being potentially different than what's being submitted to the HSCRC, and that's something that we're going to need to work with hospitals to remedy, because CMS is going to be looking at the claims they receive in terms of looking at POA and also looking at tax and potentially PPCs. I don't know where I'm supposed to point it. So this just, again, the POA indicator is assigned to all principal and secondary diagnoses. There are ICD-9 guidelines about how to assign POA. Providers must resolve issues related to inconsistent, missing, or conflicting or unclear documentation. Again, the importance of documentation can't be overemphasized, and the coders and the providers need to work together to ensure that there's accurate documentation, code assignment, and reporting of diagnoses and procedures. And it also, just as a note, medical record documentation can be, for many providers involved in care and treatment of the patient, may be used to determine whether a condition is present on admission, so that's physicians or any other qualified healthcare practitioner. So these are the different POA indicators. So if you have an ICD-9 code and a POA indicator of Y, that means yes, it was present at the time of inpatient admission. N would be no, the diagnosis was not present at the time of inpatient admission. U is that the documentation is insufficient to determine if it was present at admission. And W means that it's clinically undetermined, so a provider is unable to determine whether or not the condition was present at admission. There also are some ICD-9 codes that are exempt from POA reporting, and those would have an E as the POA indicator. So the HSCRC does POA auditing to try to identify potential systematic errors in coding practices within a facility. And the aim is to flag potential problems that are observed in rates that exceed a reasonable threshold for certain coding practices. The HSCRC contracts with an independent auditor who reviews all ICD-9 diagnoses on the HSCRC discharge abstract data and looks at the POA indicators and compares these to the documentation in the clinical charts. There are two types of audits, and one is in order to assess the quality of the POA coding, we select a subset of cases to audit that meet criteria historically for some proprietary screening algorithms that were developed by MPA. So I'll just go to the next slide. So this is what we've used in the past. These are examples of the POA audit screens. So you might have diagnoses, for instance, that are exempt from POA coding, but they are assigned not an exempt code. So those cases would be pulled. We also have things like if there's improper coding of something that we know is a chronic condition. So by definition, it really should have been present on admission. There's also things like if you have elective surgical cases that don't have any coded complications, but you have a longer than average length of stay, those would be pulled for potential auditing. Or if you went in and had a secondary diagnosis that was in a POA indicated of yes for a condition that's kind of contraindicated if you're there for an elective surgical procedure. So arriving, with a high fever and having that present on admission before a hip replacement. So again, the auditor that we've hired will look at both the ICD-9 codes and the POA, and they will do this special part of the audit. The auditors report back to hospitals the results of these audits. We calculate coding accuracy by looking at the number of coding errors or changes that they find divided by the total number of codes reviewed. We have found that we do pick up a higher proportion of issues with POA coding using those PINE screens that I talked about. But in general, hospitals have met the 95% benchmark for APR, DRG, and POA coding. So going, so this is just actually a screenshot of the POA summary and audit report. So at the top, it looks at the POA quality audit, that's the section that's used where we pull cases based on those screens, and it looks at the proportion of cases. So in this case, it's 21 out of 65 cases reviewed had a POA issue. So that's 32% versus the coding audit. So the other cases that are just randomly picked, for, we found only a 3.6% number of cases with a problem. And then below, it's the percentages by code. So for the POA quality audit, they reported, let's say, no for POA, and there were 8 cases with a POA change that was required, and there were 19 POA changes needed. Overall, then, the percentage of codes with a change needed would be 1.5%.
What was the common area with the no? Was it?
So they do provide examples of what the issues are in the back of the reports. So they say, is this no really was supposed to be a yes, or was it, or something else, like exempt?
For those districts, for example, usually they are not. They are supposed to be no, and they are coding them as exempt or yes.
I thought this error was saying that they coded something as a no, and that was wrong.
Correct.
Right.
Exactly.
So it should be
Yes.
exempt or
Exempt or yes. So in the example, very screen example is majority of the obstetric complications. They can't be. They coded no. It should have been yes. Right. So they say it's not present on admission. So they say,
right, like a chronic condition, coming in with a chronic condition, and that most likely didn't develop in the hospital. Okay. So for fiscal year 2014, we are selecting 10 hospitals for auditing. We're primarily focusing on the hospitals that have had significant improvements in PPC rates. We are also going to select 50% are going to be for the ICD-9 audits, and 50% are going to be used the POA audit. So it used to be only 30% were done for that POA quality audit. And we're still working with Pine to determine if we're going to be able to use their screens this round. But if we can't, what we're thinking of, and even if we could, we may go with this new method where we're looking at we might select from a file of discharges at risk for PPCs that we saw had larger improvements, and those PPCs where we may have seen a status change between the preliminary and the final data submission. And we also might increase the number of hospice cases that we potentially audit.
Is the 230 total or 230 per hospital?
230 per hospital. So some of the other factors, we also focus on larger hospitals, and ones that hadn't been audited in the last couple of years, and ones that had the higher percent change between preliminary and final.
Can I ask a question? I'm actually back a slide, the one with the summary results.
Yeah.
What's your, are you happy with those results?
Yeah, I mean, I think we are, we generally have set some thresholds, and we do look, every time a hospital's audited, how they compare. If we saw a much larger than what we see from other hospitals, then we might look into some sort of corrective actions.
So we've been looking at AHIMA doing 95%. So all of the hospitals were above the 95%. But through the years, we had a couple hospitals that we kind of saw their error rate was much higher than the other hospitals, and we work with them. Usually what happens is we send the cases back. We have that dialogue through the auditors to understand what the issues are, and then they develop a plan to make corrections to the coding, and then they report back to us what they implemented.
I have a question about the purpose of this. So it looks like the purpose is to catch errors so that everyone's kind of doing the same thing the same way.
Yes.
course, the original reason for PPCs was to help prevent these conditions. And hospitals were implementing various different processes to reduce that. I'm wondering what the HSCRC is doing to find those programs that do have significant reductions, not because of errors, but because they're doing a really good job and they're doing something well, and how do you transmit those best practices to all the other hospitals in the state?
Very good question. I will turn to MHA.
Yeah, and that's a question that members have been asking of us to help them to understand and learn from each other. So we are working, Nicole's on the line, she could talk more to this, but I think I can just give a quick overview. Our idea is to look at where there have been improvements in PPCs and areas where we know that just anecdotally hospitals have said, we're doing this, this is working, and to bring that together. So we should see something shortly. The big help is that the change this year is there's much more, with the change in how the policy works, much more willingness and interest in doing that.
Just as a background, the PPC adjustments used to be a relative adjustment, so it mattered what the other hospitals were compared to your hospital. And we heard from the field that it created a barrier to willingly share what each hospital were doing. Now we went to a point system, and I think that kind of reduced that barrier, if not eliminated.
Makes a huge difference. As well as setting a statewide target that is related to what is the % penalty.
Yeah, that was a great change, because otherwise you don't want to share. It's a zero-sum game, so I'm going to hold my secrets to myself.
I think at the end of the day, we all care about the improvement. You know, we want to make sure we don't care how much penalties we are assessing. Really, what is important is to provide the improvement.
I do want to comment that a few years ago, when it was hospitals somewhat pitted against one another, it was also much more an issue of dollars at that time. And now, because dollars are no longer the issue, since everyone is doing well, the concern really is overall quality and not wanting to appear that you're not in the higher echelons of quality. I just think everybody's working harder, as you say, because they can now share. There's a lot more collegiality among clinical documentation improvement specialists and coders and nurses, the nurse-sensitive PPCs, for instance. There's a lot of work together about how to work with those.
One other comment. I remember when we were first going through these PPCs and all the meetings that we had to discuss them. Has there been any kind of second look at the ones that you have now, which ones really aren't worth following, and dump those and new ones that might be helpful?
So we actually moved to having all 65 PPCs included now that we've moved away from the excess cost. But we've tiered them in different ways to try to put more emphasis on the high prevalent, high cost, sort of more amenable to improvement PPCs, as well as marking some of them as what we're calling serious events that just should never happen.
Do you think you have all that you need? I'm thinking about, for example, patients who wind up going through alcohol withdrawal because somebody didn't catch that they were addicted, and they go through surgery or something, and now they're getting DTs, and I'm not sure that that's really covered.
Yeah, I mean, I think there are probably additional quality measures we could be looking at if there are standards out there that are being used.
In general, PPCs are, surgical-oriented, majority of them. That's a major limitation. And throughout the years, that clinical process of vetting the measures, we hear a lot from hospitals, clinicians saying there is a problem with this specific definition, and we are the intermediary between 3M and them, so we gather people and 3M's been very accommodating in terms of when we find things, they make their effort to change the definitions. So there is that improvement going on in the existing PPC measurement, but certainly I think we will look beyond the PPCs and see what other measures that we would like to have.
I do have one question, and I don't know if this is the time to bring it up. If it isn't, please tell me. But one thing that I think all hospitals are looking at, there is such a wide variation in how many of the 65 PPCs apply to hospitals, and it becomes very striking, the differences in very, very small hospitals. For instance, the #1 hospital is McCready, which is very tiny, and only 6 PPCs apply out of the 65. So it becomes very difficult to understand ranking at all. And again, we're all happy that that no longer involves the dollars in the way that it used to. But it does become confusing about understanding tertiary versus the very small hospitals.
So the other change we made that resulted in, so every hospital now have their own PPC list, because we eliminated the minimum at risk less than 10, and also expected has to be at least 1. So that created different lists for each hospitals. I'm hearing it's creating some challenges for hospitals. At the same time, that kind of molds the PPC measurement to the type of patients each hospitals are seeing. So, you know, from the measurement perspective, it's not the same, you know, yardstick for everybody, but at the same time, it is applicable to the type of patients everyone is seeing. Yeah.
Okay, so we're going to move on to looking at some of the MHAC modeling that we've done. We're going to start with looking at some of the handouts. So if you could look at C.1. So what we did was we took fiscal year 2014 data. That would be actually the base period for rate year 17. And we used fiscal year 14 as also the also for the norms. And what we did is calculated the benchmarks, the thresholds, and then we calculated the points for attainment that hospitals would receive. So this is similar to what we did last year. So we used the same exclusions, and again, what we're doing is anything less than 10 at risk or 1 expected, that PPC gets excluded. And we're looking at the observed to expected ratios, and we're comparing them to the threshold and the benchmark. The threshold is set at 1, and the benchmark is the weighted mean of the top quartile. So if you look at the handout, what we have is each of the PPCs and what the calendar year 2013 benchmark was, and then what the full fiscal year 14 and the last 6 months of the fiscal year 14 benchmark would be. So again, our concern is with the 24% reduction in PPCs in the second half of fiscal year 14, if we use the whole fiscal year to set the benchmarks, hospitals will be, you know, much lower than that already. So we would like to consider using just the last 6 months of fiscal year 14 to set the benchmarks. So they're sorted again in terms of the largest difference between calendar year 13 and that last 6 months of fiscal year 14. So you can see, so for other surgical complications, the benchmark in 2013 was 0.507, and now it would actually be 0 if we just use the last 6 months of fiscal year 14. Again, the benchmark is when you would get the full 10 points for attainment for that PPC. And so between the threshold of 1 and the benchmark, which in this case would be 0, you would receive partial points for attainment. And again, then there's always the points for improvement as well. So I'm going to stop there for a second and see if people have questions.
I'll start. I think it's good to look at this. It may also be, I would also like to look at how the thresholds have changed, because just to see what's that difference that we're looking at between a threshold and a benchmark. When I see a lot of benchmarks at 0, maybe, just looking maybe like 10 PPCs would now have a threshold, a benchmark of 0. I'm just remembering back to our conversations when we were identifying last year which of the PPCs we thought could have a 0. And the discussion was that even though some of the PPCs are, the name sounds as if they are events that should almost never happen, these are still potential. And like the NQF definition of a serious reportable event has a lot of exclusions in what kind of case can be considered, whereas this, the PPCs cast a wide net. So any case, the cases don't have a lot of exclusions, the ones that are eligible for the PPC. So the discussion was that if you just look at the NQF serious reportable events, there's maybe a handful that sound like these, but the actual cases that would be eligible are much fewer because a lot of things are excluded. Whereas here, those eligible cases for those same kinds of, what sound like the same kinds of reportable events are actually broader. So that word potential has a lot more meaning here. So that's my thing that I would want to look at further before saying, oh, this sounds good. Just have a look at that.
This is the first time everyone is looking at it. This is not by no means our proposal, so we are kind of open to discussion about how to deal with this issue of the big improvements you see in the last 6 months. And remember, we are going to set the benchmarks with the fiscal year number. Your measurement is starting in calendar year. So there's also the 6-month gap already that you are catching up. So this has been our, I think, ongoing issue even in the old program. When we set the benchmarks with the base year, we are continually improving. So benchmarks is already historical, so it's always, and then at the end of the year, hospitals had 18 months really to hit that benchmark. And at the end, we always had this skewed distribution and not a correct measurement. In the public reporting field, for example, if you do this kind of things, you just take the existing measurement period and look whether they are above or below the average. With the payment program, we need to give the base year so they can know their targets and then they can improve upon. So I do agree. It's concerning that there might be ways to adjust those zeros that we see that are not never events. But at the same time, so if you look at it, the benchmark for calendar year 13 is 50%. So for a hospital to get a full point, they have to be 50% below the average in the base year. And for fiscal year 14, you already see now it is the 35%. Then you see a big, sometimes big differences when you just look at that 6 months. So you see that the majority of them are already past that benchmark.
Julie, the other concern is, first of all, I do agree with what Tracy has said. I think we're all thinking about those issues, especially some of the never events, which we know we're going to see at some point, no matter how thorough the quality program. The other issue is hospitals knew that the waiver and our agreement, all of the hospitals' agreement, was to really put quality in the foreground and to try to get our middle-of-the-road status changed nationally. And I know everyone is looking at us. The other thing that concerns me is the 8%, because even though I think hospitals surprise themselves, every time I look at how much the whole state has improved, I have to say I'm amazed. But I do know everyone is thrusting quality forward. Just try to find a quality employee right now. It's next to impossible. But I'm wondering how we're going to adjust the percentage of the goals in coming years because when you have that much improvement, low-hanging fruit has a whole other meaning, and we're now up to high shriveled already. And that I don't even have a clue how, I'm just speaking for LifeBridge. We worked extremely hard. We had teams everywhere. We just decided to get a grip. I have no idea how we would even make 8% next year. And I think a lot of hospitals are thinking that. So will we also be looking at those targets, again, based on the amount of improvement? It doesn't mean just because there's that much improvement that that is an easy attainment. I just want to make sure that's clear.
Yep.
I think that's a good point. And in my mind, they're related. What we've talked about before, how much improvement can you reasonably expect? And I think what we've heard what we've been encouraged to look at is where are the top performing hospitals, and that's kind of what you could expect to get to in general. And so I think with these ones where we've seen that big improvement, I think those are a great place to start. And what I'd like to do is take these PPCs, take them back to our clinical folks and say, does this make sense? Are you comfortable with that? Is this something reasonable? And have that clinical look at it before saying yes, no. And then the other thing that I would like to do is make sure we have this discussion in tandem with what Barbara was saying. How much improvement do we expect? And then what does that payment spectrum look like? This year we had a payment spectrum that went from 4 to half, I think? 1 to 1. Okay, 4 to 1, -4 for the performance on the low end, and 1 for a highest performance.
Oh, I'm sorry. I thought you were talking about the two different scales based on the 8%.
Yeah, it was. I'm confusing myself. That's what I am talking about, that payment scale, the two different scales, depending on whether we hit the statewide target. But what I'm thinking about now is that if I remember right, when that payment scale was set, we used, you have to remember exactly how, you have to remind me exactly how we did that.
So I'll actually just jump to the second handout because that actually has it. So if you go to 2.C.2, this is what we did last year, and you can see what we did is calculated the attainment scores for the hospitals in the base period, and the scores went, these aren't, they're sorted slightly differently, but for calendar year 13, I think went from 0.017 at the low end to 0.8 at the high end. And so what we've done is the exact same thing, but using, again, the full fiscal year 2014 and the last 6 months to get what would be the range of scores that would set up the scale. So if we use just the last 6 months, the scale is going to go as it's set from 0.18 up to 1, and that's because McCready has 1. And we could talk about whether or not McCready should be included in this scale. If you didn't include McCready, then it would be 0.74 would be the top of the scale, which is lower than it was last year.
Yeah, exactly. This is exactly where I was going. So I'm glad we're talking about that. When we look at this and when we look at how the benchmarks and thresholds change, I want to make sure that we're still making sure that our focus is on having hospitals improve, having low PPC rates, and that there's not so much penalty aspect. Clearly, we still have room to improve.
That's exactly the point. That's what we want to do, make sure it's improving. So if you don't, in our view, if you don't adjust somehow, I'm not saying this is the way to adjust it. If you do it a backward historical threshold, that means even if they deteriorate, they may still hit the higher score because the benchmark and threshold are low. So to improve, like to incentivize continuous improvement, you need to make sure your targets and benchmarks are set appropriately. So, I think we can kind of find a way to make that happen. What we are concerned is if we don't take into account this last 6-month issue, then the benchmarks and thresholds are going to be lower. And if a hospital, even if they are deteriorated, they could still score high points. And the way the scale is constructed, it's based on the attainment, right? So that means if hospital doesn't improve, nothing changes from their fiscal year 2014 rate, then this is the score that they are going to get. Any improvement is going to bump their score. And since we are looking backwards, if they improved in even that period that we are not measuring, they are bumping their score already. So we just need to make sure, I think we are all in agreement there, how do we calibrate the scale and the benchmarks to make sure that we are still incentivizing an improvement and not banking on what already had happened.
Yeah, and I think maybe what I want to do is look at last year's scale and what the steps were and compare that with what we might be looking at for this year. Because I'm thinking you either want to change, either you keep the payment scale the same and change the thresholds and benchmarks, or you keep the thresholds and benchmarks the same and change the payment scale. But if you change both, then it becomes very, very hard to get a positive payment adjustment and much more likely to get the negative payment adjustment.
That's an interesting point. To me, they are linked. But yeah, we'll so the last year is its actual calendar year 2013, right? Yep.
And
maybe we'll put the
right where the cutoffs were for the improvement or for the positive incentive.
It will be helpful also if we give them what is right now the actual penalties are. When you look at it, actually, the lowest score we have is 40.4.
Right.
So based on the old scale, the maximum penalty was going to apply to a hospital with 0.17 score. Now our lowest is 0.4.
Yeah.
So that kind of is a good way of looking at how things shift from the base to the performance. In terms of the range, there's, if you look at it, there is not much change between the minimum and maximum. So I think the scale itself is similar in my view. It's changing for each hospital depending on what we are doing with the benchmarks and thresholds, but the scale is 0.18 to 74. Yeah. There's not much change there. So yeah, I think.
So right. So what we did was we set that 8% statewide target, and if we don't hit the 8% improvement, then the maximum at risk was 4%. If we do hit that improvement, then the maximum was 1% with the potential for some positive incentives. And again, those are the things that we still have to discuss of are those the right cutoffs. And again, we're still in continued discussions with CMMI about whether our aggregate amount at risk for our qualities programs meets what CMS has.
That's quite a clip. At 8%. 7.9, no.
If we get questions like that all the time. If we get close, are we?
Yeah.
When do the benchmarks have to be established?
December.
Okay. One of my questions, and again, I'm more of a finance guy than a quality guy, obviously, but in just looking at the number of zeros that go into the last 6 months, I mean, it's actually over 40% of the total number of PPCs are now with a zero, and I think that means it's almost like a never event at that point, right? So I guess my question is, are we able to peel that onion back a little bit or even roll it forward before we do the benchmarks to make sure? I thought some of them were like cumulative measures where if you have one, it kind of changes you for the period or something like that. Is that not the case? In other words, I'm worried about the zeros because using a 6-month clip instead of a 12-month clip, regardless of whether it's more recent or not more recent. So even if we had to roll it forward a little bit or split the difference or something.
And I was thinking maybe rather than using 6 months, we can use full month, but then apply a reduction factor. You know, that would not get you to 0. It's going to get you something different. So that's a different thing I would like to model.
I think this is what you're saying, but from the fiscal perspective and the quality perspective, it may sound a little bit different. But also, if you just think of the likelihood of error, even in very good hospitals, is different for a year versus 1 month versus 6 months. So that's why using 6 months, and I think that's what you're saying, but I'm just thinking from the quality perspective, the likelihood of something occurring. When I say hospitals are worried about sustaining their changes, that doesn't sound good. But if you put that in perspective of 6 months versus a year, it makes all the sense in the world. You know, a hospital may be able to guarantee, let me just choose a simple one, that I don't know, an OB laceration might not occur in 6 months, but for a year it would be really hard to say that that wouldn't occur at all. So I really think we are going to have to look at how we set those benchmarks very carefully, both dependent on the amount of improvement so far and the time. I wouldn't base it on 6 months.
So I heard you say maybe scale, you know, the payment points could stay same if there are not much variation. And then let's look at some other ways of taking into account that improvement rather than using 6 months. And I think on the benchmark, we are going to put actual rates. It seems a little hard to imagine what it would take you to have the less than 50% of the average, because you don't know what the average rate is. So we'll put those in too, so you can kind of see, of the 100 patients, what is that really? Is it 1 ppc, 10 ppc? So that may also help us to think about more like implications of these benchmarks.
When you do that, will that also show what the denominator, kind of to Justin's point of is 6 months enough or do we need a full year?
Okay. The next slide we had on here is, again, we just wanted to, we were comparing our programs to the CMS programs, and really quickly just, again, we had the expected numbers needed to, we're excluding if it's less than 1 and less than 10 at risk. And we just took a look at what CMS's rules were for their HAC program, and complete data for the ARC PSI 90 composite measure would mean that they have to have 3 or more eligible discharges for at least one of the components. So that's a lot less than our 10 potentially at risk. And then for the standardized infection ratio, it requires that the facility have at least more than 1 predicted or 1 expected. So that's sort of in line with ours. And again, if they can't, if they don't meet the criteria for having the standardized infection ratio score, then their entire score would be made up from the PSI 90. So again, I think our numbers are either more liberal or at least in line with what the CMS programs are. And then this last slide, which we already looked at, we were looking at this because we do need to set the statewide improvement target for fiscal year 17. And so this was looking back historically at the target and showing if I can, if I can read it correctly, that the average annual change from fiscal year 2010 to 14 has been 15% reduction in the number of complications and a 13.9% reduction in the risk-adjusted complication rate on average.
So we haven't started discussing with CMS what the PPC target is, I'm assuming we'll do shortly. Our target for 5 years was 30%, and I'm 99% sure they would want to adjust that. Our annual target, we need to kind of keep in mind what feedback we receive from CMS, but at the same time, these are the numbers on the average. So last year, I remember when we discussed the 8%, the average was showing around 12, and we were very concerned even with the 8%, and we surpassed it quite a bit. And I do understand maybe that was the easy things to do. Now it's going to be much hard. That was also the argument last year too. So it's hard to really think about what is the appropriate level of improvement you would expect.
I would say, though, that most hospitals, again, we hear this at our meetings at MHA, and we hear it in the community. We all finally also cleaned up our act on some of the issues of coding, the accuracy issues, the definitional issues. So that's why I was saying the low-hanging fruit was that piece, but then we had to dip into the quality very deeply this year. But that's what I'm saying. I think it would be hard to separate out how much was cleanup and how much was quality this year. And it would also vary by hospital. Some hospitals had a lot more cleanup to do than others in terms of whether it's POA or coder accuracy, audit, et cetera. I don't know that we'll know that. I'm told. So anything else on the MHACs? Yeah,
Just good questions, don't have any answers. Yes, but all the right questions.
And I guess the plan on the, it's going to be a package, obviously, with the benchmark thresholds, target, and the percentage risk. And, probably next meeting, we may also start discussing about the percentage risk. Hopefully, we'll hear from CMS what our calculations are. And that discussion also needs to happen in the payment work group simultaneously, and we're going to vet the recommendations in both work groups. So I'm told that our speaker is also stuck in the traffic, but should be here shortly.
I'll just ask a question. You mentioned at the start that you were planning to have draft recommendations at the next meeting, and I think, if I remember from the work plan, also at the November commission meeting.
Correct.
How much of this, each of these pieces, will be in that recommendation, like of the thresholds, the amount at risk? What will be in and what will be left to further discussion or determination?
So the time may slide a little bit because I realize the percentage risk discussion needs to happen all together. Originally, we structured this as stepwise QBR, MHAC, and readmission, and I've been thinking since they all need to be taught together, we may need to push. We're going to get back to you on the timelines. But in general, the commission is approving the policy question, so aggregate at risk, state target will be definitely in the recommendation. The threshold benchmark is kind of in the weeds, more technical, so we would probably have more time to think about and finalize it, by mid-December. Unless Stan tells me otherwise. Oh, yeah, while we're waiting, good idea.
I'm wondering if there's any comments from people in the audience at this point, since we're sort of concluding the MHAC portion and waiting for our speaker. So the scores? So for the full fiscal year 2014, we used the benchmarks and thresholds that were established if we use the full fiscal year 14. So from the other handout, and for the last 6 months, we then used the last 6 months.
And maybe you can explain the differences in PPCs. We didn't get to that one on this table. So when you do 6 months versus 12 months.
Right. So with the exclusions of the less than 10 at risk and less than 1 expected, we did see some change in actually what PPCs were counted, including some additional PPCs are being added if you use just 6 months versus if you use the full fiscal year 14. These are ones where the expected was right around 1. So for the whole fiscal year 14, it might have been 0.93, but the last half of fiscal year 14, it was 1.03. So it would then jump into being an included PPC. And then, of course, there were some that dropped that weren't. So we put on here what the PPC difference count would be based upon that. And I think if, again, you know, if we go back to using the entire year, but then making, you know, some adjustments, applying some sort of reduction factor, then we would end up with the PPCs that are included for the full year, fiscal year 2014. On here. So when what we did was we doubled the number of expected and at risk. So we took the 6-month data and then doubled it so that those expected numbers could stay the same. We could have done it the other way.
While we're waiting, on this other sheet here, could you remind me how, so you said that if you used the calendar 13 benchmark at 0.5, 0.5070, so that means that the benchmark would be 50% of the average, right? So if you go to 0, it means it is average. The benchmark starts at average, or is it actually?
So, so these benchmarks would be the weighted mean of the top quartile, and the weighted mean of the top quartile in 2013 was 0.5. But the weighted mean.
So the average is 1 in this case.
Correct.
These are the ratios. So hospital score divided by the state is, if it's average, it's 1. Right. If it is 0, that means you're expecting 0 complication rates.
Okay.
And again, Tracy, you talked about wanting to see the thresholds. So the thresholds are 1, but we did set the thresholds for the never event, serious reportable events at 0, and that might be something that we look at. But the ones that are where they're not one of the 5 serious reportable events, yet the weighted mean of the top quartile equals 0, for those the threshold would still be 1.
Right. Okay. So maybe what I'm thinking of now that that light bulb went on is more that not to see the thresholds, but to see the rate.
Exactly.
And to see how much change there was there. That might be.
Yep. Very good.
Maybe while waiting, we'll give you an update on the readmission policy or our plans for the readmission program. We've been meeting with CMS on the readmission measure. So we have a target, again, for the readmission to reach the national average or below by the end of the 5th year, if you remember. And originally, the algorithm to define the readmission was based on patients, partnership for patients. And their plan was to take that number and then compare us against the national benchmark. We brought the issues around the subunit issues. We think that in the national data, the psych beds and the rehab beds are excluded from those numbers, whereas in ours they are probably included. because we don't have separate IDs. In the national one, there is, and our guess, since we didn't see the data yet, we think that they are not. They are excluding in the national data set, but they are not. They can't in our Maryland data. And then the other issue that they brought up is the issue of the enrollment. So since we're looking at the 30-day period, if the patient dies or enrolls in the MA plan, they show up as no readmission. They are index states in the base, but you won't see any readmission because, again, they don't see there is no claims from the Medicare Advantage plans. Or if the patient died outside of the hospital, they are not excluded. So those are the two adjustments we think are probably going to help us also because we have low mortality rate in general, and we have low Medicare Advantage enrollment too. So those two may be inflating our readmission rates compared to the national.
I can certainly verify that, especially psychiatry.
Mm-hmm.
So let me just make sure I understand you. You are strongly considering mimicking or going along with the CMS definition.
So CMS is considering to revise their existing. We've been going with their definition. If they make changes to theirs, then we will try to adapt them as possible. But that will help us in terms of how bad we look compared to the national. You know, we've been struggling to understand why our readmission rate's been high, and these could be I would call measurement issues, not the care. So if they agree to look at those, and then they are hiring a new contractor because they didn't have someone to look at the readmission rates, so they're going to be looking in more deeper and then try to see if adjustments are warranted.
And what is the timing on that again? What is the timing that you think we will know that?
I'm really bad with the timing. I'm very optimistic and then get burned by it.
That 6 months ago.
Time's here.
So I don't know. I think at least this, like the optimistic one is December, I would say. So I think we would need to still deal with some incomplete data, try to look at the trends and see, you know, what our benchmark should be. And we are going to be receiving data, so we can do some of those ourselves. But again, I think that timeline is also December, January. Hi, good morning. We reserved a seat right there for you.
I'm so sorry I'm late.
We had a terrible time on the Beltway this morning.
No.
Yes.
My apologies. I know I started
we have time until 11, I think we are scheduled. Is that right?
11:30.
11:30?
Scheduled to. Yes.
So we have.
I just want to apologize in advance. I may be called back to the hospital, so if I have to walk out, you'll understand.
Sure. Okay. So you are the only topic. So 11:30, yeah. So we have an hour.
Okay, super. Well, thanks so much for the opportunity, and thanks to Tom Valek, a colleague, former colleague of mine at NQF. It's delightful to be here, and I had a chance to just learn more about what Maryland's doing. I mean, we're so close, and yet, you know, you're not always keenly aware of what's going on in your environment. Learn more talking to Tom, and of course, what a fabulous write-up in that recent New England Journal of Medicine article. So let me dive in. I have been at NQF for 3 years, and I oversee congressional affairs there. I have a long background in quality. I was at the Institute of Medicine and the National Committee for Quality Assurance. I think what I'd like to do today with the time we've got is really give you a very one-minute introduction to NQF for those of you who do not know, talk about what had been our risk adjustment policy and what motivated our expert panel's work on this topic,
talk about the broader policy context because I'm on Capitol Hill a lot, and this is a very intense issue on Capitol Hill. Explain the project, the scope of it, our recommendations, and talk a little bit about the trial period and next steps. So just a minute on NQF. I know you guys are all performance measurement geeks, so you know a lot about it, but just in case there are some in the public audience who are not aware, we are an organization that sets standards for performance measurement. We focus on improving health and healthcare through using performance measures, and our two main levers are endorsing performance measures and convening stakeholders to get buy-in about what's the most important things to measure, how to measure, and how to move our healthcare system toward higher performance. As you all know, we can have the best evidence-based performance measures, but if we don't have the buy-in in our very decentralized healthcare system, we're not going to be able to move forward. So we have to balance both the evidence and our consensus-driven process. We have over 400 members. They come from every part of the healthcare system. We have a consumer purchaser majority in our governance, which I think makes us quite unique. We're based in Washington, and we're 15 years old this year. We already had adjusted measures for clinical factors, and that's not a surprise to any of you, obviously where it was appropriate. And we've had a policy for the last 6 years prohibiting the adjustment for socioeconomic and sociodemographic factors. As you probably are well aware, SES factors can influence outcomes in a variety of different ways and also could be related to disparities in healthcare. A word on nomenclature, what you probably hear a lot about is SES, and we think of our work in terms of examining this topic to be broader than that, both SES, which would include education, income, occupation, but also demographic factors like race and ethnicity, primary language, things in the community that might have an effect on patient characteristics. So this is from a recent journal article in Cardiovascular Quality and Outcomes, and it was an analysis of what could affect congestive heart failure. And you know, there are many, many factors, including obviously clinical factors, but also community factors, and they call out SES in particular. And so this is just to show you the myriad of factors and how they all intersect. Why did we take on this work? CMS asked us to, in a nutshell, but also what were they responding to? Increased use of outcomes in their programs and private payers as well, and knowing that there are other factors beyond the control of the institution or provider, and wanting to understand what effect they have on performance measurement. Growing evidence that, and so we have this evidence. We also know that higher financial stakes are being tied to outcome measures, and there has been a lot of concern on the part of safety net providers in particular that they may, that the outcome measures that they're reporting may not be reflective of their actual care. And also, while we have seen healthcare outcomes improve in some places, and if you look at the ARC data and some other national data, and it hasn't improved everywhere, but we've seen it in some places, disparities have really not moved the needle. And so this was also prompted this work. In terms of the policy context, you know, whenever you've got sort of the collision of concerns about a policy on vulnerable populations, a concern that this may be impacting the safety net, and then it affects money, that's like a perfect storm for policymakers to examine existing policy and to think about whether or not it needs to be modified. On Capitol Hill, we've heard a lot from congressional staff that the hospitals, particularly the safety net providers, have been concerned about the readmissions program, and health plans have been concerned about the star rating programs and the effects of SES. Federal laws have been introduced, and I'll spend a moment talking about them, as well as state laws. And we were getting a lot of requests for input from congressional staff as they wanted to respond to their constituents. While we were in the throes of convening this expert panel and developing our recommendations, generally we work in sort of everything is open and transparent, and everyone can come to our meetings or listen in our webinars, and mostly people don't pay attention until we come out with our recommendations. But this issue is different, and in fact, it got picked up not only in the trade media, but also in the New York Times. So it sort of broke through and got more into the mainstream. In terms of the federal policy, very quickly, there's both a Senate bill and a House bill, and most that have been introduced to address hospital readmissions and SES. And there's also been a bill that was passed and signed into law at the beginning of October, focused on post-acute reform and putting a quality measurement infrastructure in place that has SES provisions. In terms of the House bill, it's a bipartisan bill. There's now upwards of 100 sponsors on it, and it's very narrowly constructed. It requires CMS to adjust the readmissions measure for dual eligibility, and then to use that measure to determine payment. The House bill is, the Senate bill has fewer sponsors, just 10, and it's more nuanced. It suggests that there are many other factors that should be considered. It broadly defines SES, and it suggests that each year there should be a re-examination of what are the appropriate factors to adjust for. It also requires HHS, if they want to not adjust the measure and want to look at some other approach, like peer group, grouping by peers or stratification, that they do an analysis, a comparative analysis of its different approaches. So it is open to other approaches, but suggests that first CMS would need to do a comparative analysis if it wanted to consider another approach to addressing this set of issues. And then the bill that was signed into law sets up and requires there to be 2 studies done to look at SES effects on performance measurement, first using Medicare data, and the policy agency within HHS would do this study over a 2-year period, and then a broader study to go outside of what data Medicare currently has to bring in other data and examine SES more broadly. The purpose of the study is to really understand what effect SES has on these measures, and if they find that there is an effect, CMS is directed to make recommendations about how to collect the relevant data to account for the SES factors in both quality and resource use measures, and then to account for that in payment. And this is over a 5-year period, and there are funds put aside to do this work. I think $6 million, if my memory serves. So that's the policy context in which NQF was doing its work, and this was happening at the same time. These bills were being introduced as the expert panel was convened and looking at this issue. So what were we focused on doing? Again, examining the issues related to risk-adjusting measures for SES and related demographic factors, making recommendations for if, when, for what, and how outcome performance measures should be adjusted for SES or related demographic factors. But it was more than a white paper. the expert panel was also asked to make recommendations for NQS endorsement criteria. So rather than just, here's a paper to inform the academic literature, no, panel, you must make a recommendation back to NQS. And so the questions that we were focused on: does adjustment mask disparities or meaningful differences in quality? Does it create different standards of care? And are sociodemographic, socioeconomic factors different than what we've already been doing through our adjustment of clinical or health status factors? This is our expert panel. There's a number of individuals that have long been working in the area of disparities. Many of them have affiliations which some would think are some thought that they were providers, and believe me, this panel list got analyzed to understand who was on it, and we were explaining to the news media and many other stakeholders that many of these individuals, well, yes, they do work at academic health centers, are disparities researchers and really bring that level of expertise. They're not representing providers. And as the discussion emerged, and almost from the beginning, there were really two very different views. Well, I think those on the panel had shared goals that we wanted to enhance and not do anything to undermine care for vulnerable populations. So we want to enhance care for vulnerable populations. We do not want to harm the safety net. And we want to improve overall quality. So there were shared goals. There really were, two different approaches and two different views, that adjusting for SES could mask disparities and further worsen care for vulnerable populations. And the other view was that adjusting for SES was absolutely essential to be able to have comparative data. And what you're trying to do with performance measurement is use standardized measures that can discriminate performance, and that you really have an apples-to-apples comparison. So those for the proposed adjustment for SES, they argued that what you would be doing would be institutionalizing worse quality care for disadvantaged populations, that you would adjust away meaningful differences in quality, and that you could expect worse outcomes, that providers who were taking care of vulnerable populations were changing their practices to go outside of the hospital doors and to make all kinds of adjustments to the way they were delivering care. And if you adjusted away SES, then they would retreat from that kind of, those kinds of changes to the delivery system. Also that we were, locking in this different standard. There was a lot of arguments that, even if we put this policy in place, we do not have adequate data, and so, we would have very crude ways to adjust, and it would be it would not get the outcome we were hoping for, and that many folks felt like instead of adjusting the measure, we should be adjusting the payment. Others, and this did not necessarily fall along, provider, consumer, purchaser line. It was interesting. There were providers that were uncomfortable with the notion of SES adjustment, and consumer groups that really thought that we should adjust for SES. So it didn't necessarily fall on those lines, although majority views as you would expect. So support adjustment for SES factors, this will allow for true comparative performance, the apples-to-apples comparison. Even if we had a performance score alone, that would not allow us to identify disparities in care, that hospitals caring for the disadvantaged are already being penalized, and by, because they have this more difficult population to care for, and if we don't adjust, it only will be worse for them. There's no evidence over all of these years that this lack of adjustment has driven improvements and no evidence that disparities would be reduced through further negative financial incentives on the safety net. A lack of adjustment will continue to create a disincentive for safety nets and other hospitals to care for poor patients. So the key points that the expert panel made, and again, the expert panel was making their recommendations to NQF, remember that earlier slide, and what they basically concluded is that under appropriate conditions, performance measures should be adjusted for SES. Now, and I know Tom made this point in a prior presentation, again, it would need to depend on, is there a conceptual basis? Is there empirical data to demonstrate that there is a relationship? And only then could you adjust. This recommendation was broad. It applied to hospitals and health plans, individual clinicians, all settings of care. So that was their recommendation back to the expert panel, the expert panel's recommendation. And through the comment period and a lot of discussion with the CSAC, which is the umbrella committee that oversees all of the evaluation and review panels at NQF, a compromise was reached about how to proceed. And so while the expert panel had made a pretty clean set of recommendations, the board modified those slightly in the final report. So what I'm going to relay here in the next couple of slides are the three most important recommendations that are in the final report, which I know you all have received. So the recommendation was, instead of immediately changing NQF's criteria to adjust where appropriate for SES, that instead NQF should embark upon a trial period, lifting its current prohibition against adjustment and bringing in measures for consideration that would be adjusted. Endorsing those measures, which would then, those endorsed measures would go, if CMS decided to put them into programs, back for review by MAP, and MAP, which is the multi-stakeholder convened group, the group that NQF convenes, would consider them for various federal programs. And so during the trial period, if SES adjustment is determined to be appropriate, we would endorse the measures. We would endorse the measure, but it would have three component parts. There would be the SES adjusted measure. There would be a non-SES adjusted measure, so adjustment just for clinical factors. And then the non-SES adjusted measure would be stratified to be able to see whether or not there were disparities. And so this endorsed measure would have three components. And that was really where we got buy-in from the broader community, that it wouldn't just, you would be able to compare the SES adjusted measure and the non-SES adjusted measure, and also you would have this stratification so you could see the disparities. So the compromise was trial, not absolute change of the criteria, and this three-prong approach. So our trial period will begin on January 1st of this year, and we are preparing for that. In addition, it's a 2-year trial period. Yeah. In addition, NQF would convene a disparities committee to monitor implementation. And I think once we put a standing committee in place, it's likely that this committee will go on past the trial period, because I think that there are many other issues that the disparities committee could review at NQF. And it would also, the recommendations also called upon NQF to work with CMS and ONC and ARC and others to develop strategies to identify a standard set of socioeconomic and sociodemographic variables that could be used in adjustment. So a little bit more about the trial period. These are the kinds of questions that we intend to ask. So one is we're going to want to know when we look at the measures that we think should be adjusted for SES, does that have a significant effect on the measure? What measures and what effect might it have for different subgroups? So we'll want to look at that. If a strong conceptual relationship exists, we're going to want to do the analysis to look at the empirical relationship. We also will be identifying through that process, and I think this will inform the work that we'll do with ARC and ONC and CMS, really where do we have data gaps? You know, where can we get income information? What do we need to know about community variables? Where does that data exist and where does it not? And then we'll obviously be looking to see if endorsed SES adjusted measures are recommended and used in public reporting and pay-for-performance programs. That's what we can do, we think, over a 2-year period. Longer-term considerations, you know, we'll really want to understand how are hospitals, health plans, and eventually physicians reacting to SES adjusted scores. What happens in terms of their behavior? How do purchasers and payers use this data? And do SES measures and stratified results have an impact on disparities? At the end of the day, that's the million-dollar question. As I said earlier, these longer-term issues will be tracked by the Disparities Committee. So I hope you can see that this is a very complex issue with a lot of moving parts. We obviously, you know, have been talking about this in the academic literature for some time. What we do need is better data, more evidence, and better research to really answer a lot of the questions that people have about whether or not risk adjustment for SES makes sense. This has generated so much passion, so many comments, more comments than NQF has gotten on any other project to date, and obviously, you know, very diverse views. And yet we can't just sit in the ivory tower because there are real implications right now for safety net providers. And so immediate action is required. And the Hill, you know, is thinking seriously about taking action. And so I do know that the House and Senate are discussing a compromise bill that they hope will be introduced in 2015. We have said to them that we think it is, we think that the science is evolving and that to put anything into statute we would not recommend, but I think they have many others who think otherwise. And also, as you might imagine, other approaches are being discussed. And so MedPAC is in constant conversation with the Hill as well, and they've got some other ideas about peer groupings and adjusting payment. In all of this, CMS is a very pivotal player because they help to support measure developers and can direct measure developers to consider these factors. They're going to decide whether or not measures are put into payment programs. But I do believe they will be under considerable pressure. I know that as soon as this bill was signed by President Obama on October 6th, a letter went right from the Hill to Secretary Burwell to say, you know, we really need to look at this issue. So please direct the agency to do so. You know, I think we always need to come back to, we have shared goals here. We may disagree on what's the appropriate path forward, but we do think that this trial period over the next couple of years, if it is a robust trial period, if we do have measures that come through the endorsement process and are put into programs, will help us to, will give us more information to help us move forward. Thank you very much. No questions, comments?
I just have a question on the nomenclature. So in the report, you talk about SDS in here, and you've been talking in your presentation about SES. Are the demographic features included in the SES, or is that something separate?
No, it's, so the way because the whole broader community talks about SES, and the expert panel felt much more comfortable with SDS, but as an organization, we are saying SES and other socio-demographic factors, so it is to include that much broader array, but the shorthand has become SES because that's just how the broader community is considering it. But our definition is much broader.
The reason why I ask is, we've been challenged with the racial and ethnic disparity issues and trying to get, of course, for our purposes, we tend to use administrative data, and it's been, several years where we've been in this curve of trying to get the data to a really good spot, and there are a lot of challenges to that. So obviously, to be able to do a really good risk adjustment tool, you have to have really good data.
Yeah.
Do you find the same problem did your group find that there are issues related to that in trying to get good data, and if so, did they have any suggestions, recommendations, resolutions to that go into the future?
The data issues are real. There's a section of the report that looks at what are the available data sources that we know of right now. I think it's very helpful to have that bill that passed, that impact bill that will direct research, will be much better informed about what data Medicare currently has, and then this 5-year study to look outside of Medicare. The committee discussed that that's how we started with adjustment of clinical measures. The data was not very good. The initial adjustments were pretty crude, and over time, having that policy in place drove, the collection of the data so we could have more robust adjustment. And so the expectation is that that would happen here as well. Also, our colleagues across the pond have been doing this for some time. They adjust both for clinical and for socio-demographic, socioeconomic factors. So,
yeah, I think the difference is in the past with coding on clinical measures, it's the doctors and nurses and folks inside the hospital that we needed to improve coding. The difference here is we have to, get the right information from the patient in the first place, which is a different challenge.
Mm-hmm.
So as a psychiatrist focused on quality, one of the challenges is that we still have a very non-integrated system when it comes to behavioral health and physical health, oftentimes different payers.
Yep.
So different sets of claims data, a lot of it doesn't merge. I was on a Medicaid work group 2 years ago where we put together data from the MCOs and from the managed behavioral health organizations for Medicaid and found that, for example, we looked at like 10 different DRGs. For diabetes, for example, patients who had a combination of mental health and substance abuse problems were admitted for diabetes 13 times more often than people with neither mental health or substance use, and intermediate for either mental health or substance use. So, but nobody realized that until you put the silos together. So I'm wondering what your group has done particularly around behavioral health, and making sure that data, which is often hard to find, doesn't get lost in the shuffle, especially given the fact that we know that the disparities around mental health, people with chronic medical conditions die 10 to 15 years earlier.
Yeah. That is a really, really good question. We have been doing a lot to build out our measures in the behavioral health area, and so
I just submitted one actually. So
great. So we're kind of on the third round of bringing in measures, and we even now have some, I think, pretty innovative e-measures in that latest round of measures. We've also been doing a lot more work in Medicaid to define a core set. And we've been doing work around alignment between states and Medicaid. We're looking at that issue around aligning the same set of measures. But you're asking another question, which is about the effects of behavioral health issues on performance measurement. And I don't know. I mean, I'm sorry, I'm not able to answer your question whether or not that's considered a clinical adjustment, or is there, that would be a SDS, SDF. I don't know the answer to that question. I don't know if anyone sitting around this table does.
I know in one of the documents that came in our set, it said that it talked about complexity being part of the SDS measurement, and people with combination chronic medical and mental health conditions were considered to be in that package. So it sounds like it might fall under that. In this disparities monitoring work group that you're setting up, do you have adequate representation from mental health specialists?
Well, sounds like we should. We're just beginning to put together the that expert panel. We put all of our slates out for public comment. I invite you to look for that slate, and I'm happy to take your card and make sure you get it and can comment. I think you're making a really good point, and I would imagine that the folks who have been advising us all along would probably suggest that we have someone with that expertise on the panel.
Great, thank you.
Anne, I had a question. Is it your expert panel that'll determine which outcomes are actually adjusted for SDS, or is there a bucket like hospital-acquired conditions that won't be adjusted? Has that been decided?
So what will happen, and I think that the readmission measures are likely to be the first measures that are under consideration for SES adjustment. So that expert panel will look at the measures that come through, and the question will be basically, is there first this conceptual relationship? For hospital-acquired conditions, I think the answer would be no, because it does not matter what patient characteristics you have. A introduction of an infection in the hospital should not be adjusted away. That clearly would be, indication of poor quality on behalf of the hospital, and you would not want to mask that. So I think that wouldn't pass the first test. Mm-hmm. So each panel will look at the measures submitted and raise the question about is there a conceptual relationship, and then the next thing that the measure developer would need to do is bring forward the empirical data to demonstrate here is this relationship. And then that panel will consider. We call them, they are the committee that comes together around a given condition or a given measure. So they will make their recommendation, which in our current structure then goes to the Consensus Standards Approval Committee, and then goes out for member voting. And the CSAC considers both the expert panel's recommendations and the member vote. They have their own vote on that set of measures, and then our board is asked to ratify or not the measures. So that's how it works in our current process. We are re-examining that process right now to try to determine if it still makes sense, all those various pieces. I will say that as measures become more consequential for payment purposes, it's becoming more challenging to get to consensus.
Yeah.
So are there, you mentioned obviously everyone knows CMS is very actively involved in the readmission measure. Do you know if they are already funding some of the measure development? I would imagine, everyone kind of, it's an important topic, everyone on the radar, but sometimes it's really hard to find funding to do measure development.
Yes. So they have suggested that they will be supporting this work. They've said that publicly. Patrick Conway has. And so I do not know that any contracts have been let, that direct the measure developer to consider these factors. But they have said publicly that they are going, to support this work. So it hasn't been that long, and as you might imagine, these things take a while. There's also, and not many high expectations that this will happen, but in the SGR reform bill, there's $15 million per year over a 5-year period for measure development. And that is to come out of the trust fund, so it wouldn't even be that it would need to be appropriated. It would be there if that bill passes. So I think that there is an acknowledgement that this is expensive work. It's work that, it's for a public good. There's really not a great, ask NCQA or any of the academic health centers or the specialty societies that develop measures. It's not really a good business case for developing measures and then putting them in the public domain. I mean, there's no way to generate income from them, and there's a whole lot of expense. And so, we're really appreciative and actually have worked on Capitol Hill to make the case to congressional staff that we really do need public dollars as well as private dollars for measure development.
Any other questions?
Thanks for the presentation. It was really helpful to have you and talk and explain in a little more detail about the process and the nuances. And I think we all can really appreciate the importance of taking the time to make sure that this gets, these decisions are made thoughtfully. And you mentioned the pressure that CMS is under to do something maybe more quickly. And I think we feel that same pressure too. I definitely feel it coming from the Hospital Association and hearing members' concerns. You probably know that under the waiver agreement that we just entered into, we have a readmissions target to hit, among others, but that one is kind of foremost in our minds. And then I'll say that we're also, hospitals are working really hard to reduce avoidable utilization, and prevention quality indicators are maybe one subset of that. And I think the prevailing thought is that those prevention quality indicators are also influenced by socioeconomic, sociodemographic factors. And while there hasn't been any particular policy to say we're going to measure your PQIs and adjust your payment based on that, those avoidable utilization is sort of creeping in to policy, payment policy in different ways and influencing that. So we're feeling the pressure on readmission, feeling the pressure on avoidable utilization, and the need to understand better how the population influences the hospital's performance on that. So all of that preface to say, do you have any recommendations for Maryland and having this right in front of us now? And I think there is some interest in maybe revising our readmissions payment policy, which in this past year said set a target for every hospital, the same target, same reduction target. There is some interest, and it's controversial, of whether there should be different targets for different hospitals. So any advice on that? Any advice on avoidable utilization?
Well, maybe take a page from MedPAC, and there's people that disagree with this approach, would be to group the hospitals into peer groups based on the proportion of patients that meet some criteria, whatever that criteria is, for high SES, and then to look at their performance within that peer group. You know, I mean, I think that, well, and then write it up and then share what you learn. I mean, I think that would be the other piece of advice because, you know, what we hope is that this whole discussion and the report, which, boy, did that expert panel work, you know, long and hard on and, you know, really tried to bring together all, you know, available evidence that existed and, you know, they wrote up the methods. It's going to take, you know, a lot of concentrated effort on the part of policymakers and researchers and people who really understand, you know, this very complex area to, you know, get to a workable policy. So that would be one suggestion, and I know you already do this, where you know, publish things, and I would just encourage you to keep on doing that. Yep.
I had another question about the SES. You know, you mentioned the neighborhood community factors. Can you talk more about how the community saw the differences between what would be a community effect versus what the individual patient effect? Because, you know, the income, for example, or poverty could be impacting the patient, but if they are living in a deprived neighborhood, then it might have even more significance for the outcomes.
Right. So, and then there's other things as well. So they looked at things like, you know, income at the zip code level and what effect that might have. They looked at things that there may be some data on that, you know, marketing, you know, that marketers have. Things like proportion of, related to food deserts and, you know, is there adequate access to high quality food? Might look at transportation networks. That would be a community factor. You know, apart from individual factors like health literacy. So this is a complex picture. You know, if you're thinking about, you know, the individual and they're nested in a community and what those factors are. We are fortunate to be at NQF to be doing a 3-year study with ARC that's looking at the intersection between public health and the medical system at the community level. And we are about to announce the 10 communities that have come forward to work with us on revising a community guide related to, you know, how do we think about this integration and move towards better population health. And so the recognition is, you know, Washington just goes and does that. You know, not going to be very effective. We really need the innovators on the ground who are trying to do this and understand and can give advice to each other and to the broader field. So we've got, I mean, I'm excited that this is happening, and maybe the events of the last number of weeks may also propel this forward.
I just want to make one comment. First of all, I'm speaking for my own hospital system, not all, but I think we would really applaud seeing this move forward. I think, especially since I have a very diverse system and one hospital is located in one of the most difficult zip codes in the region, I do think our challenge, your challenge, all of our challenges to try to somehow quantify and measure that accurately, because I do see that that's very challenging. But I just want to say I really appreciated your presentation, and I think we are really preparing ourselves such that it would be helpful to have that kind of a stratification.
And I think what some, thank you very much, I think what some systems will find, you know, large systems, is that when there is this adjustment, the hospitals that disproportionately are serving a higher income population may end up looking worse, while some of the folks who are serving a higher proportion of vulnerable populations may look better. And I think, you know, there's so much emphasis on, you know, the safety net, but I think maybe this has not been focused on. You know, there'll be other effects on the upper end, and so it will be some challenges, I think, within the system.
I think you're absolutely right, but I think that we have all struggled, especially as we add readmissions to the cycle, recidivism. There are limits to what the hospital environment can do for prevention as we look at the circles that we can move to in the community. We can't control the whole community, and we try as much as possible to couple with community organizations to help. But I think this would assist us in identifying where those very difficult regions are, also perhaps in looking for other funding to help some of those patient situations. So it may have many layers to it, but I think what it could certainly do is be the beginning, or at least another benchmark of where we can go to improve care and to hopefully prevent certainly avoidable utilization and recidivism. So great. Thank you. If I can.
Well, thank you. We appreciate you coming to present to us today, and thank you to the committee members. Is there anybody from the audience that has a question?
I actually received one online from Amy Duschender from Hopkins. The question is, with the CMS definition, are we still talking about all-cause and adjusted Medicare readmissions? Yes. Also, in the discussion of exclusions for psych and rehab transfers, we also need to include oncology transfers, as these are some same provider and have a discharge and admin associated with it. Right before you came, we were explaining our CMS measure, and we had conversations with CMS to even the algorithm itself seems like needs some work, especially if you're following the patient within 30 days, the change in enrollment, the mortalities, they all need to be taken care of. And in Maryland, we think that we have another case where our distinct units are not separated from our acute hospitals. So in the algorithm for the national estimates, they take out the rehab and psych beds where they have separate IDs, whereas in ours, it is in. So if you're, and this is a crude adjustment, there's not even clinical adjustment on our test. So then I think we think that since psych and rehab has higher readmission rates, it's increasing our state average. And what it's not about transfers per se. It's about the type of patients that we would have in the measurement. They are not typical. They wouldn't be typical acute care if the rest of the nation is excluding psych distinct units. So that's the adjustments that we are working on. And oncology could be or could be not. Again, in the state, we don't have separate oncologist hospitals, so they are part of the readmission measure as well. So, we are looking at even in the clinical area, what kind of adjustments needs to be made. And again, I just wanted to, transfers is already taken care of because transfer is not counted as readmission. So this is about the patient mix in the rate.
Boy, it's complex, right?
Yeah.
And that's why, you're talking to a 25-year-old staffer who says, so we want to put some language in the bill about, exemptions and, the specification for the measure. And I'm going, oh, my God, just like, do not do that. I mean, I imagine that that measure will be re-examined as it comes back through for SES for all kinds of things, probably including, maybe some of the things that you've mentioned. And this is also why, we have these pressures at NQS to get these measures endorsed as quickly as possible because these statutory requirements for these programs. And so, there's a lot of pressure to get them through quickly. And yet, there are a whole set of really complex technical issues to resolve. And then we're trying to get to consensus.
Yes.
So it has a whole set of challenges. And one of the things we have found, and I know, you obviously operate in a very open and transparent way as well, is that the more we can increase our communication at every step of the way, so that even if people are not happy with what the final resolution is, at least they feel like they have been heard. We understand their comments. The expert panel has considered them, has made a decision, for these reasons, and so the challenge is to try to do that in a really under a time-pressured environment. So that's what we try to weigh.
And we do appreciate that. NQF was a major resource when we started our programs here, and thank goodness you were ahead of the game, and we were able to utilize all the research and vetting that you did to get our program started about 4 years ago. So we certainly have seen value in all your work, and we appreciate that, and glad that you're kind of ahead of the game on this one as well.
Good, good. Well, I think what we want to do more at NQF, and I've begun to do more on the Hill, is try to bring folks from around the country, because it can be a very conceptual conversation. And I think it behooves the broader policy community to understand, what the challenges are on the ground and how this is working and where the innovation is. So maybe we can talk and get you guys, involved in one of our panels and participating more. It's the exciting work that you're doing. All right. All right. Thanks.
How are you?
Nice to meet you.
Thanks for the presentation.
Sure. Exciting work. Must be having, must be on the cutting edge or bleeding edge.
Right. Right.
Thank you.
Oh, you're welcome. Yeah.